Hello, can you guys hear me? Hello.
Yes, doctor, we can hear you.
Okay, so today we are going to start our pathology section. So the first, okay, can you guys just see my screen?
Yes, doctor.
Okay,
Yes,
hello.
sir.
Okay, so is everyone here?
Yes, doctor. Yes. Yes, sir, we're here.
Okay, so today we are going to start our pathology section, and the first pathology of your skeletal system, which we are going to discuss, is achondroplasia. Achondroplasia. So first of all, we have to break the name. What do achondroplasia means? Whenever we see the word a, it means without or non-functioning or dysfunctioning, right? Chondrocytes basically refers to the cells which give rise to your cartilage. You guys are aware of that, right? Cartilage. And plasia, that is synthesis, right? So whenever we have problems with like cartilage proliferation, it leads to a pathology which is known as achondroplasia, right? So cartilage is an important thing, an important structure in our growth. You guys already know that. Like for example, whenever like when the skeletal system is developed, the bones mainly it develops in two phases. First of all, like there are two ways of making a mature bone. That is like in the flayed bones, for example, your skull, your sternum, there is a process which is known as intramembranous, yes, bone formation, right? So bone is formed in two ways, intramembranous, and the second one is endochondral bone formation, right? Endochondral bone formation. So like our flat bones, for example, bones of our head, our chest, sternum, they basically develop by this method or this phenomena, that is intramembranous. And what's the goal of intramembranous? Like you're first of all, you're going to have like a connective tissue, and that connective tissue is basically replaced by bone, right? So connective tissue replaced by bones. It become mineralized with time, and it would lead to development of bone. The second way of formation of your bone is endochondral bone formation. What do you mean by endochondral bone formation? You guys are already aware of, like, for example, in formation of bone, what happens? We have a plate which is known as growth plate, and growth plate is also known as like metaphysis. You guys are already aware of that. Metaphysis, above the growth plate, you have epiphysis and you have diaphysis, right? So basically what happens in endochondral bone formation, that first of all, your cartilage is going to be laid down, right? So first of all, cartilage lays down, and after that, this cartilage is mineralized, right? So it is replaced by calcium and phosphate, and in this way, you are going to see like, normal bone formation, especially in long bones. Is that clear?
Yes, can you just repeat the classification? I don't get it. Sorry,
Okay.
doc.
So normally bonds are formed in two ways, right? So you have two processes or two phenomena in which your mature bone develops. So for example, we have two kinds of bone, long bones and flayed bones, right? Flayed bones, for example, bones of your skull and your sternum, your chest, right? So flayed bones basically grow via phenomena that is intramembranous ossification or bone formation, right? What happens in intramembranous ossification or bone formation, you have connective tissue, and connective tissue with time is mineralized, and it converts to mature bone, right? And the second phenomena of formation of bone, especially in the long bone, is that first of all, you are going to see formation of your cartilage, and cartilage, like in the later stages of your life, is going to be replaced by your mature bone. Is that clear? So you have
Yeah,
intramembranous and endochondral bone formation. Is that clear?
yeah, clear
Okay.
now. Thank you.
Yeah, clear.
Yes, sir. Dr.
Okay.
Ahmed?
Yes,
Dr.
please.
Ahmed, both are the same things?
Okay. For the
First
flat
cartilage,
bones,
then they
okay.
mineralize, and then they develop it to the mature bones.
Okay, so actually, in the end, you are going to see formation of bone, right? But flayed bones occurs due to this phenomena, right? And the long bones, for example, your femur, your tibia, it mainly occur through this phenomena. You have two phenomena for bones formation, for different kind of bone formation, for flat bones and for long bones. Is that clear?
Yes.
Okay.
Yes, doc.
So we know that for the formation of long bones, first of all, we need cartilage to be laid down. Is that clear? That's the main point. Can I say that for the long bones formation, first of all, I need cartilage to be laid down? then it's going to be replaced by your mature bone. Is that clear? Can I say that?
Yes.
Perfect. So I can also say that in achondroplasia, as we already discussed, basically you can't form chondrocyte, right? So I would say that this phenomena of bone formation is going to be disrupted, while this one is fine. Can I say that?
Yes.
Because
doc.
for the endochondral bone formation, you need chondrocytes, and for the flared bones, you need intramembranous. It have nothing to do with chondrocytes. So in achondroplasia, can I say that basically you are going to have long bones being affected, while the skull bones and the chest bone, they are going to be fine.
Yes.
Okay, that's perfect, right? So you have a UL MCQ on that. What happens in achondroplasia? Basically, it is due to activating mutation. What do we mean by activating mutation? That you have a receptor which is known as fibroblast growth factor 3 receptor. Once this receptor is activated, it's an activated mutation, remember, right? Then it would lead to this pathology, right? Activated mutation of fibroblast growth factor receptor 3 is going to lead to achondroplasia, and we know that once we have achondroplasia, the long bones are going to be affected, while the flat bones, no problem with that, right? So as the long bones are affected, why? Because they need chondrocyte first. Is that clear?
Yeah.
Yes.
Okay. So what happens that you are going to have short extremity with normal size head and chest, right? Short extremities. Why? Because long bone functions are affected. Is that clear?
Yes, doc.
Okay. So the mental function is also fine. So you're going to have a UWorld MCQ. They are going to give you this scenario of achondroplasia. They are going to give you the classical feature of that with the skull size normal and chest, size normal with your short extremities due to problem with the long bones. And they'll be asking you that it's due to activating mutation of which receptor. Simple as that. Is that clear?
Yes. Yes, sir.
Okay. Let's move to our next pathology, that is osteogenesis imperfecta. You're going to have a lot of MCQ on osteogenesis imperfecta, and it's very high yield. Even in the NBMEs, you are going to have like a lot of MCQs, and even on your real exam day as well, right? So let's break down the name. Osteogenesis. What is osteogenesis? Osteo means bones, genesis means formation. Imperfecta, or can I say imperfect formation of your bone? Can I say that?
Yes.
Yes.
Okay. Imperfect formation of your bone. Okay, another thing which you guys should, it's a kind of mnemonic kind of thing which you guys can, just memorize. Imperfecta. So the word I basically resembles letter 1, right?
Yes.
Okay.
Yes.
Yes, letter 1. And bone, B-O-N-E. Bone also have 1, right? It means that bones are made up of type 1 collagen, right? So the strength of bone, basically the integrity of bone, is maintained by type 1 collagen. And what happens in osteogenesis imperfecta, which is imperfect formation of bone, you have problems with type 1 collagen, right? It's basically an autosomal dominant defect in type 1 collagen synthesis. Is that clear?
Yes, sir.
So type 1 collagen synthesis defect. If we do not have type 1 collagen, so it's obvious the bone integrity is going to be lost. If the bone integrity is lost, it means it would be prone to fractures. So what would be the clinical features? Clinical features would include bone fractures because you do not have type 1 collagen, B-O-N-E, 1, important for formation of your bone. Is that clear?
Yes.
sir.
But type 1 collagen isn't only present in the bones, it's also present in the sclera. If you guys know, right? For example, if this is your eye, your cornea, your sclera, the white portion, right? And below the eye, basically, you guys know you have another layer which is known as choroid plexus or choroid veins, right? Hello?
Yes.
Yes, sir.
And veins are blue. Whenever you see the picture of veins in book, they're basically indicated by blue color due to deoxygenated blood. Is that clear? And for oxygenated blood, basically we use color red. Hello?
Yes, right.
Okay. So
Yes, doc.
sclera also need type 1 collagen. So for example, if in osteogenesis imperfecta, we are going to have problems with type 1 collagen, so there would also be problems of sclera. So sclera would become very thin. And once the sclera become thin, what happens? The choroid plexus are going to be visible, and choroid plexus are going like basically blue in nature because they are veins. Veins contain deoxygenated blood. We basically, and deoxygenated blood is basically blue in color, right? Blue baby syndrome,
Yes.
remember. So can I say that in osteogenesis, we are going to have blue sclera? Can I say that?
Yes, sir.
Yes.
Perfect. So we are going to have blue sclera again. Okay, third thing, we know for hearing, we require bones as well. For hearing, malleus, incus, and stapes, right? They are the small bones present within your ear, right? And you guys know that they're basically attached to your tympanic membrane, and it's going to, stimulate your cochlea by an oval window and everything. We'll be just discussing that in our ENT module. Don't worry about that. They're also bone, right? If they are bone, it means they also require type 1 collagen.
Yes.
Is that clear? So can I say that we'll also be seeing some hearing loss?
Yes.
Conductive hearing
Yes.
loss? Yes.
Yes.
So in osteogenesis imperfecta, 3 things you guys have to remember, right? Imperfect, letter I or letter 1. 1 for bone, type 1 collagen problems, right? And once you have type 1 collagen problem, you're not only seeing problems within the bone, but sclera is also going to be appeared blue. Is that clear?
Clear.
Yes.
Okay. So you're going to have U-word MCQ on that as well. Simply they're going to tell you we have an individual, he have blue sclera and some hearing problems. So that's going to be like very simple to diagnose. Is that clear?
Yes,
Yes.
doc.
Okay. So let's discuss our third pathology, that is osteopetrosis. So first of all, let's break the name, right? Osteo for bone and petrosis basically refers to stone, right? Stone or hard or thick, right? So can I say that in this pathology, we are going to have thick bones because as the name indicates, osteo, bone, petrosis. So it means you are going to have thick bone. Can I say that?
Yes.
Okay. So on the first place, you guys know that, for example, if I want to lay down bone, right? So your osteoblast basically lay down bone, right? And your osteoclasts, on the other hand, they eat bone, right? They're
Yes.
macrophages. They're macrophages. They would eat your bone, right? They would demineralize your bone. But we already know that you need an alkaline environment. We discussed it, if you guys remember, alkaline environment for the osteoblast to function. On the other hand, we need acidic environment in order to, have increased activity of osteoclast. Is that clear?
Yes.
Yes.
Okay. Another thing, we also know that in order to activate osteoclast, basically we need osteoblast because osteoblast is going to, activate the rank L receptor, right? And once the rank L ligand attached to rank receptor, then you are going to have a lot of activity of your osteoclast. That's also clear, right?
Yes.
Yes.
But we also have OPGs, if you guys remember OPGs, osteoprotegerin, right? Which would inhibit rank L and in turn inhibit osteoclastic activity. Is that clear?
Yes.
Yes,
Yes.
doc.
So it means
Would
that
you
both
please,
of
excuse me, sir, would you please repeat this section? Thank you.
okay, sure, I'll just repeat it, no problem, right? Okay, so we basically know that we have osteoblast and osteoclast. What's the main function of osteoblast? Osteoblast mainly lay down a matrix which is known as osteoid, right? And osteoid in turn get calcified and phosphate is added, and then you are going to see a mature bone, right?
Yes.
Yes.
So osteoblasts are important for bone formation. Can I say that?
Sure.
Yes, sir.
Okay. And for example, if I want bone remodeling or if I want resorption of bone, so osteoclast does that because they are macrophages, they eat bone, right? But both of these processes, occurs at same time. It's not that if osteoblasts are working, the osteoclast one, because it's a kind of turnover, right? So you're going to have osteoblastic and osteoclastic activity going on in parallel with one another. But for example, if I need more of osteoblastic activity, so I would increase the alkaline environment and decrease the acidic environment, right?
Yes.
Yes.
If I need more osteoclastic activity, I have to increase the acidic environment and decrease the alkaline environment. Is that clear?
Yes,
Yes.
it's clear.
And we also know that in order to activate your osteoblast do that, right? Osteoblast would just send rank L. It would activate the rank L receptor on osteoclast, and in that way osteoclastic activity increases. Is that clear?
Yes, clear.
Yes.
Like if I'm increasing the acidic environment, so like it would just tell osteoblast again to increase the osteoclast. So osteoclast alone cannot do anything. It's just waiting for the order of osteoblast, right? So they are the king. Is that clear?
Yep.
Yeah.
Okay.
And
and-
what is the OPG? OPG secreted from where?
Okay.
OPG.
Okay. OPG again, it's all of this acidic environment by itself is made by osteoclast. So if the activity of osteoclast want to be decrease, so OPG comes, right? So what OPG would do? OPG would decrease the rank L receptor, and once the rank L receptor goes down, that's obvious that osteoclastic activity would also go down. Is that clear?
Yes. Yes. No. Yeah. Thank
Okay. So what happens in osteopetrosis, as we break down the name, it means we are going to have thick bone, right? So how can we have thick bone? One of the idea is to decrease osteoclastic function. If I decrease osteoclastic function, can I say that then I'll be having a thick bone,
you. Yep.
right? Is that clear?
Yes.
Yes.
But we also know that how can we decrease osteoclastic activity? Like I want to decrease osteoclastic activity in order to have a thick bone. But question arises how? How can I do that? So I already know the answer for that. The acidity. So what happens? Decrease the acidity, right?
Yes.
Okay. So can I say, okay, till now, can I say that osteopetrosis means thick bone formation due to less osteoclastic activity? Why do I have less osteoclastic activity? Due to less acidic environment. Can I say that?
Yes.
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 But how can we have, now next question should arise in your mind, why do we have less acidity? So the less acidity, you have to go to the physiology. You know that we have an enzyme that is carbonic anhydrase in our body.
Yes.
Right? What does carbonic anhydrase do? It would combine H2O with CO2, and in turn, you'll be having H plus and HCO3. So the acidic environment is basically given by this enzyme. Can I say that? Normally in our body,
Yes.
abundant enzyme. Perfect. So can I say that if this enzyme isn't functioning, then I can have this pathology? Like we are just breaking down things,
Yes.
right? We are just breaking down things. So if the carbonic anhydrase isn't functioning, you do not have acidic environment. If I do not have acidic environment, I won't be having osteoclastic activity. If I do not have osteoclastic activity, I will be having osteopetrosis. Is that clear?
Yes.
Yes.
Okay.
Yes.
So why do we have osteopetrosis? It's basically genetic, multiple genetic variants, which tends to decrease the activity of carbonic anhydrase too. Is that clear?
Yes.
Okay.
Yes.
Dr. Ahmed, can you please go around the carbonic anhydrase again?
Okay. Normally, what's the function of carbonic anhydrase? We already discussed in the renal section. Carbonic anhydrase basically can, okay. So for example, we discussed in, if you guys remember, the CO2 transport, right? So what carbonic anhydrase was doing there, carbonic anhydrase is an enzyme. Okay, so if I need CO2, okay, water to be combined with CO2, so you need carbonic anhydrase for that. And what would happen? This reaction would move further. It would just give us H2CO3, and H2CO3 further can dissociate into H plus and HCO3. Carbonic anhydrase can also reverse this reaction. You already know that, right? So it can also take water, like it can take, like H2CO3, and it can again convert it into water plus CO2. Is that clear?
Yeah.
So
Yes,
can I say,
Dr. Ahmed, just to remember and confirm something. During endo, estrogen was the hormone that acts on OPG, correct?
sorry?
Estrogen is the hormone that affects or acts protects the bone with OPG, correct?
I can't get you. What's your question? Sorry. OPG what?
I can.
Yes,
I
you can
can
just
tell.
yes.
Yeah, actually, there are some questions in the U word which speaking that in osteoporosis there will be reduction, there will be increase the OPG, and that's will lead to
In
osteoporosis.
osteoporosis, right? In
Yeah.
osteoporosis, you are saying? Okay, we'll be discussing osteoporosis, but actually osteoporosis have like mainly to do with, like physical activity, and it have to do with like, nutrition. If you are just checking vitamin D supplements, yes, but if you want to, like it's basically theories. You can just satisfy your concept by using the like integrating OPG. That's also good. Like you can say that, but the main thing which we have to take in consideration in case of osteoporosis is physical activity, your genetics, and your supplementation, vitamin D supplementation. Is that clear? But yes, you can say
Doc, she was
somehow that. Sorry.
asking about like estrogen. She was asking about like estrogen affecting OPG. Oh, so you
Okay,
just
okay, okay, perfect. Okay, okay, okay. I do understand. So basically, we guys know that estrogen is protective to bone, right? Hello? And we
Yes.
also know
Yes,
that
sir.
glucocorticoids are destructive to bone, right?
Yes.
So if I need bone protection, it means I need a lot of OPGs,
That's
Yes.
correct.
right? If I need bone protection, it means I do not need osteoclastic activity. I have to inhibit that. How do I inhibit osteoclastic activity? Just just increase the level of OPGs, right? So estrogen basically increases OPG, and it would decrease rank L receptor. Rank L ligand, right? Once the ligand is decreased, osteoclastic activity decreases. So in this, like it's basically the mechanism. How do estrogen, save your bone? Is that clear?
Yep.
All right.
Okay.
Yes.
Okay. So, sorry, I didn't get your question. So, really sorry about that. Okay. So, we were discussing carbonic anhydrase, right? So, carbonic anhydrase basically, we know that it basically give us that acidic environment, and that acidic environment basically increases your osteoclastic activity. So, what happens in osteopetrosis? The carbonic anhydrase activity is gone due to certain mutation. If it's gone, so what happens? Osteoclastic activity is gone. So, you have increased osteoblastic activity. But an important point which you guys should remember, although we have like a thick bone, but that thick bone isn't strong, right? Because you have increased osteoblastic, and it's a pathology, by the way, right? So you won't be expecting that your osteoblast is just laying down, a strong bone, although the bone is thick. So you can just imagine it as a chalk, right? Chalk is thick, but you can simply break it off, right? Is that
Yes.
clear? Okay, another thing which you guys should know that we discussed that, for example, if this is your bone, the metaphysis. So in the metaphysis, you have your medullary. Okay, this is the cortex of bone. Cortex is basically lined by periosteum. If you guys remember, periosteum is the connective tissue, and you have your medulla, right? In the medulla, you have your bone marrow. Bone marrow have hematopoietic stem cell, which can give rise to all of your myeloid and lymphoid lineage. Remember?
Yes.
Okay, so can I say that if I have a thick bone, so what happens? This thickness can go inside, it can replace the medulla. So on X-ray, you won't be seeing the medullary portion. If I'm replacing the bone marrow, the medulla, so can I say it would lead to pancytopenia, anemia, thrombocytopenia, leukopenia?
Yes, sir.
Okay,
Yes.
perfect. Okay, another thing, we know that the cranial nerves, okay, we have like 12 cranial nerves, right? Once they just move out of, the brain, so they have to pass through certain foramen, if you guys remember, right?
Yes.
Hello? Okay, if the bone is becoming thickened, so can I say that the lumen of this foramen is also going to be narrowed? So it
Yes.
can impinge upon the cranial nerve. So in this pathology, I'll also be, this guy is going to experience some vision problem, some hearing problem by the compromise. If the cranial nerve 8 is compromised, if the vision problem, are you guys just getting me?
Yeah.
Yes.
Okay. We also know that basically the brain have, you have a foramen magnum, and for, the brain is present like somewhere here, and you have your cerebellum. We'll be discussing. So for example, if you have thick bone formation, so this foramen magnum can also become narrowed, right? And it can lead to hydrocephalus, increased pressure if I'm just narrowing it. So it can lead to hydrocephalus, right?
Yes.
Yeah, so it can lead to hydrocephalus. Another thing which you guys should not forget, renal tubular acidosis. If you guys remember, like for example, if these are our renal cells, our lumen, so how do we reabsorb bicarbonates, HCO3? For that, we need carbonic anhydrase activity. Remember type 1, renal tubular acidosis.
Yes.
Okay. So what happens
Yes.
that in carbonic anhydrase, basically it have to generate, H plus would just move out, and the carbonic anhydrase is again going to, reverse this reaction. It's going to give CO2. CO2 again is going to come inside. Again, carbonic anhydrase is going to convert it into H plus and HCO3, and in this way H plus is going to be reabsorbed, or HCO3 or the bicarbonate are going to be reabsorbed. So we already discussed the details. So can I say that carbonic anhydrase is also important for reabsorption of your bicarbs, right?
Yes.
Okay, if we have problems with carbonic anhydrase, you cannot reabsorb bicarbs. Can I say it would lead to acidosis?
Yes.
And specifically renal tubular acidosis. Is that clear?
Yes.
Okay.
Can
So
you
here,
repeat this point? Last point.
okay. So have you attempted the renal lectures? Hello? Hello?
No.
No.
Okay. Okay. Those who haven't attended the renal lecture, let me just do that for you guys, right? So for example, if these are our renal tubules, right? And in the lumen, you have your bicarbs, right? That is HCO3. Hello?
Yes.
Yes, sir.
Or if I want HCO3 to be reabsorbed inside my body, what's the mechanism for that? First of all, you have H2O plus CO2. Carbonic anhydrase is going to convert it into H2 plus HCO3, right? And this HCO3 is going to move out. It's going to trap the HCO3. It's going to be converted into H2CO3. Again, carbonic anhydrase is going to convert it into H2O plus CO2. CO2 is going to diffuse inward. Again, it's going to undergo the same process, and you are going to see reabsorption of HCO3 in the end. Simply, you can remember, if we need to reabsorb HCO3, one H plus is going to move outward in order to trap that HCO3. And HCO3 here is going to be reabsorbed, right? Hello?
Yep. Yep.
Right.
Yes.
Okay. So it means that we need carbonic anhydrase activity to reabsorb HCO3. Can I say that?
Yes.
Okay. Why? Because carbonic anhydrase have to generate H plus, then it have to trap HCO3 and reabsorb it in the end, right? So if in this pathology, the carbonic anhydrase isn't functioning, so I would say we cannot reabsorb HCO3. If I cannot reabsorb HCO3, it means it would end in acidosis.
Yes.
You aren't reabsorbing the bases, so inside your body, the quantity of acids are going to be increased. This is going to lead to acidosis. Okay, what do you think? What should be the treatment approach for this condition? Yes. Okay, I want you guys to
Acetazolamide. Acetazolamide.
Okay, okay. Okay, if the problem is in osteoclast, so what do you think? How do you fix that problem? Yes, anyone?
Marrow transplantation.
Okay, perfect. Bone marrow transplantation. Why? Because we know that osteoclasts are, bone macrophages. Macrophages come from hematopoietic stem cell. We already know that, right? From the monocytes, it would turn into macrophages. So if we just gave bone marrow transplantation, in this way, the osteoclastic activity can be, regained, right?
Right.
Yes.
Okay. So let's discuss our next pathology, that is osteomalacia and Rickets. Okay. So, okay. Are you guys able to understand? Hello?
Yes, doctor.
Okay.
Yes, doctor.
Okay. So the next pathology which we are going to discuss is Rickets and osteomalacia, right? But before discussing that, okay, Rickets and osteomalacia. So what happens in both of these pathologies, you should just keep in mind that both of these pathologies are due to vitamin D deficiency, right? But if we have vitamin D deficiency in children, we are going to name it as Rickets. If we have vitamin D deficiency in adults, we are going to name it as osteomalacia. Is that clear?
Yes.
Okay, so we know that what's the function of vitamin D. We already discussed it in a really detail in the renal section, if you guys remember. How do we get vitamin D first? Sunlight is falling, it's going to be converted to 25 hydroxy calcitriol. Then we have 125 hydroxy in our renal proximal convoluted tubule. Remember?
Yes, sir.
Okay. So 125 hydroxycalcitriol, it's the activated form of vitamin D. It's going to go into your intestines, and in intestines, what happens? It's going to reabsorb your calcium and phosphate, right?
Yes.
And calcium and phosphate we discussed. It's important for mineralization of your osteoid. You know, osteoblast would lay osteoid, and mineralization of this osteoid in turn would and in formation of your mature bone, right?
Yes.
Okay, so can I say that whenever we have vitamin D deficiency, again, we are going to see bone problems. You can't mineralize your bone, right?
Yes.
So
Yes,
how can
sir.
we get vitamin D deficiency? Just come from here. You know, sunlight is important for that. So for example, those individuals who aren't just taking like enough sun exposure, they can have vitamin D deficiency, right? Another thing, for example, in the liver, we discussed it's going to be hydroxylated, 25 hydroxylation. If you have liver problems, cirrhosis, again, it can also lead to vitamin D deficiency. Can I say that?
Yes.
Okay, we need proximal convoluted tubule because it have an enzyme 1-alpha hydroxylase, which is going to, you know, convert it into activated states. So CKD individual can also have this condition. Can I say that?
Yes.
And what about A, D, E, K? They are fat soluble vitamins, right?
Yes.
But you also get vitamin D from your nutrition as well. So if there is any problem like with pancreas, it can also lead to vitamin D deficiency. And in turn, what happens? The bone is going to be weak, right? You're going to have weak bones. Is that clear?
Yes, sir.
Okay, and we discussed whenever we have vitamin D deficiency in children, it's going to be called as rickets. Whenever it's in adults, we are going to call it as osteomalacia, right? So let's discuss rickets. What happens in rickets? We already know that it's due to vitamin D deficiency, right?
Yes.
Yes,
Okay.
doc.
Okay, so what's specific about rickets? Remember that in this pathology of children, you are going to have pigeon breast deformities. Why? Because as we are going to have weak bone, so as a result of that, you'll be having a characteristic feature. That is, the ribs are going to be bent inward while the sternum is going to be protruded. The sternum protrudes and the ribs move inward. It would result in pigeon breast deformity, right?
Yes.
Okay, so you have a word MCQ on that. You will be seeing frontal bossing. Why? Because if you cannot mineralize the osteoid, osteoid is being made by your osteoblast, but the problem is you cannot mineralize it, right? So what your osteoblasts are going to do, they are going to lay down a lot of osteoids, and lot of osteoid lay down in your like forehead. It's going to end in frontal bossing. Is that clear? Due to osteoid deposition in the skull.
Yes.
Right?
So
These
can you just repeat the frontal bossing part?
okay. So as we know that although we are going to see formation of osteoids, osteoids are formed, but you cannot mineralize it, right?
Yes, yes.
Okay. So what your osteoblasts are going to think, they're going to think that if you do not, okay, osteoblasts mainly, you know, think that we must have a mature bone, right? A mineralized bone. But if you can't mineralize that, so what osteoblasts are going to do? Osteoblasts are going to lay down a lot of osteoid, right? Waiting for the hope to be mineralized, right? So they'll be hoping that it can be mineralized in the future. But what's the problem? They'll keep on laying down a lot of osteoid in different places inside your body, including your forehead, which is going to end in frontal bossing.
Yes, okay.
Is that clear? Okay, osteoids are also going to be laid at costochondral junctions, right? Your costochondral junction. So it would just resemble, you know, a beads of osteoid deposition in costochondral junction, which is basically known as rachitic rosary, right? Rachitic rosary. Rosary are basically the beads on which, you know, people worship, right? Like you have the beads like that, if you guys know, you know,
Yes.
and you know, like that. So people usually worship on that. So rosary for those beads due to osteoid deposition, and rachitic, it's due to, it's in the rickets, right? In rickets, you are going to see this condition. Is that clear?
Yes.
Yes.
And if we have osteoid in our long bones, but they aren't, you know, like a kind of strengthened by mineralization, so it's going to lead into bowing of your legs, bowing of a child leg, because they are so weak, they are, you know, flexible, right? If they are just walking, it would lead to bowing of legs. Is that clear?
Yes.
Yes.
Okay, perfect. That's perfect, right? Okay, so we have already discussed, okay, let's discuss osteomalacia. The idea is really clear. Osteomalacia, again, vitamin D deficiency. We discussed how can we get vitamin D deficiency, but in adults, right? Okay, so if you have less vitamin D, it means you cannot mineralize the osteoid, you cannot mineralize the bone. So it's obvious the bone would be prone to fractures.
Yes.
Let's discuss some lab findings. If the calcium is low, so what would happen to PTH? Yes.
Hi.
Increase.
Okay, PTH would be increased. Okay, and as we already discussed that we have increased osteoblastic activity because it's laying down a lot of osteoids, right?
Yes.
So for the osteoblastic activity, do we need alkaline environment or an acidic environment?
Alkaline.
Environment.
Okay,
Alkaline.
perfect. So what will happen to alkaline phosphatase?
Increase.
Increase. Perfect. That's all about ricket and osteomalacia. Is that clear?
Yes.
Yes, sir.
Okay. Okay.
Yes.
So let's discuss our third pathology, that is osteoporosis, right? Osteoporosis. So what do we mean by osteoporosis? The idea is really clear. Osteo for your bone and porosis for your porous bones, right? There are a lot of pores or weakened bone, right? Can I say that?
Yes, correct.
Okay, so we are going to have like a porous or a weakened bone, that is loss of trabecular bone mass. So first of all, if you want to dig into this pathology, for that you should know that how our bone growth is affected. What factors lead to maturation of your bone, right? So we have a term which is known as peak bone mass. So what do we mean by peak bone mass? As the name indicates, it's like the maximum strengthened bone which you can get throughout your life. Is that clear? The maximum, mature and strengthened bone which you can get throughout your life. So basically you achieve peak bone mass at 30 years of your age. Is that clear?
Yes.
Okay. But in order to have peak bone mass, there are certain factors which are important for to get as much as peak bone mass as possible, right? So there are three factors. One is exercise. If you are exercising more, it means you are going to have, a way more thickened and strengthened bone. So the peak bone mass can be achieved. And at that stage, at 30 years of age, normally for an average individual, the bone would be like quite strong. Is that clear? Second thing is, yes, vitamin D receptors. Vitamin D receptors, right? And it have to do with genetics. Those who have strong genetics of their bone, they're going to have, thickened or like strengthened bone at their 30 year of age, or in other words, they will be having a good peak bone mass. Is that clear?
Yes.
And third is your diet, right? If you are just taking in a lot of vitamin D supplements and a proper diet, again, your peak bone mass at 30 years of age would be quite great. Is that clear?
Yes.
Okay,
Yeah.
but what happens after 30 years of age as the age keep on decline? So normally in every individual, 1% of this bone mass is lost, right? Okay, but you can also control that if you are just keeping a proper exercise schedule, if you are just keeping a proper diet, so you can just further slow down the process. Is that clear?
Yes.
And you also know estrogen is also important for that. So in
Yes.
female, mainly if the estrogen wanes out in postmenopausal woman, so it can also have a increased loss of bone after 30 years of age. Is that clear?
Yes, sir.
Okay, but after 30 years of age, if we aren't keeping good exercise, if you aren't keeping good diet, so what happens? This bone is going to decline way more faster, and ultimately you are going to end in a condition that is osteoporosis. Is that clear?
Yes, sir.
So if you guys see, there is like not a specific thing involved. Like it has something to do with exercise and diet. Like it have nothing to do with some increased osteoplastic activity and things like that, right? So what do you think will happen? Okay, how to diagnose this disease? First of all, look for the labs. So the labs would be normal, right? Is that clear?
Yes.
So you're going to have a lot of keyword MCQ. First of all, you guys have to look for the labs. If the labs are normal and still a patient is complaining of some bone problems, think of osteoporosis. Is that clear?
Yes.
Okay. What else that, okay, where do we have problems arising? Like, for example, if we have porous bone formation, okay, there is some noise in someone's mic. Okay, thank you. Okay, so what happens that, okay, just give me a second. Okay, so basically this individual with osteoporosis is going to complain of those areas which are, prone to weight bearing exercises, right? For example, vertebra. So they can be like, they will be complaining of, like I cannot pick a lot of weight, or kyphosis, that is bending of their vertebra. So these are going to be the things and the complaints which this individual is going to have on, right? Hello?
Yes, doc.
What would be the treatment? Treatment is so simple. Tell them to exercise, tell them to have a lot of calcium supplements, a lot of vitamin D supplements, right? And estrogen therapy, although that's debatable, right? That's like, it's debated, you cannot do that. But in theory, we know that it, decreases the OPGs, so it can help in some way, right? And it can decrease the osteoclastic activity. Is that clear?
Yeah.
Yes, doc.
And glucocorticoids, you don't have to give them glucocorticoids because they are already declining, and glucocorticoids are basically not destructive to bone. We already discussed that. Is that clear?
Yeah. Excuse me, doctor. May I have a question
Yes.
about the diagnostic? If the lab is normal, should we do here the DEXA scan?
Yes, yes. There is also a scan which is known as DEXA scan. So what's the main goal of DEXA scan? It's going to look for the bone density, right? We already know that in this pathology, we are going to have porous bone. The density is going to be lost. If the density of the bone is lost, it's then going to lead into osteoporosis. So yes, that's perfect point which you have mentioned, DEXA scan. So in order to look for the bone density, DEXA scan is an important diagnostic tool.
Just-
Is that clear?
Yes, doc.
Okay. So let's discuss our next pathology, that is Paget disease of bone, right? Paget
Disease of bone.
disease of bone. Okay. Anyone have any idea that what happens in Paget disease of bone?
Imbalance between osteoblasts and osteoclasts.
Okay, perfect. So what do you
Yes.
think, okay, which like osteoblast activity is going to be, increase or osteoclastic?
Increase in osteoclastic.
Osteoblast.
Okay, who are saying osteoblast? Raise your hands. Hello?
I think both of them, but then
Yeah, like
then
it's the
regular
big
fashion.
the osteoclast and then the osteoblast.
Okay,
There is an
perfect. So,
order. It occurs in an order.
Osteoclast activities will be increased.
okay, perfect. So for that, you have to look the initial activity. So initially, osteoclastic activity increases, right? And then in the end, osteoblastic activity increases. So let's just, for remembering or for mnemonic purposes, so my mnemonic for that is, let's call it as Paget disease, right? Paget for C for osteoclast, right? Osteoclasts, right? So the initial thing which is going to happen is increase osteoclastic activity, right? So the story is that first of all, what happens, the osteoclastic activity increases. Why do we have increase? We do not know the specific cause, but the etiology can be viral, right? So the virus infection can, basically increases the osteoclastic activity. And what happens? Osteoblasts are going to sit and they'll be just watching, right? So what's the problem? We know that normally in normal individual, if we want to increase osteoclastic activity, basically osteoblast does that, right? Via rank L, remember?
Yes. Yes.
But what happens in this pathology? Virus is going to come and is directly going to tell osteoclast to increase your activity. So, the osteoblast will be just sitting and watching, right? So what happens? It's going to eat a lot of bone, right?
Yes.
Okay, if a lot of bone is eaten, so what happens in the end? Osteoblast would just think of that osteoclast is just, acting without my commands, right? I'm not sending any rank L, but it's, eating bone again and again. So ultimately what happens? Osteoblast would just come into play and it would just lay down a lot of bone, right? A lot of bone, but it would do everything in a quite rush, right? So it would obviously lay down the bone, but the bone would not be that strong, right?
Yes.
Okay, so the first phase is osteoclastic activity. Then we have missed osteoclastic and osteoblastic, and in the end osteoclast would be just drained out, and in the end osteoblastic activity dominates, right?
Yes.
Okay, and once the osteoblastic activity dominates, what happens? It would lead into, like, a bone, but that bone would be, like, quite weak.
Fragile.
Fragile bone. Okay. I don't know what's happening to my. Just give me a second. Just give me 1 second, please. Hello? Hello, can you guys hear me?
Yes.
Yes.
Okay, there is a problem. Really sorry for that. My device get heat up, and I think I cannot continue the lecture. So we'll be just doing it tomorrow. Really sorry for that. I'm just trying to fix it, but it needs some time to be, code. So you guys can see I cannot even scroll down, right?
No worries, sir.
Okay, so I'll just fix that, and tomorrow I'll just plan of getting a new device for myself. So thank you so much for staying here, and already the time is over. Hope so you guys enjoyed the lecture. Did you guys enjoy the lectures?
Yes, of
Yes.
course.
Yes.
Okay.
Yes, sir.
Yes, sir.
Thank you, sir.
Okay, that's perfect. Okay, one thing which you guys have to remember is just get prepared for your research as well, because next week we are going to announce the research and you guys have to participate in that. And we have some topics remaining, so tomorrow we are going to have a big kind of class. We have to wind up things, but really sorry for today. I think there's some problem. My device just get heat up. Okay, thank you so much, and see you in the Discord server, right? So just take 15 minutes of break and just come to Discord. I'll be just waiting there, right?
Thanks.
Thank you, sir.
Okay. Thank you so much. Thank you so much. Have a nice day. Bye bye.
Bye. Bye.